Welcome to the Rural Social Worker Closing the Gaps Despite the Distance podcast. I am your host, Andrea Charles, and this is the space where we will delve into the heart of rural landscapes and explore the essential role of social workers in bridging the gaps in rural social work. Join me as we navigate the unique challenges, celebrate the triumphs, and uncover the stories that shape the fabric of rural life. Together, let's embark on a journey to understand the transformative impact of social workers in the forgotten communities of our nation. A quick note, while our discussions provide valuable insight, please remember that this podcast is not a substitute for official supervision or guidance in your professional practice. Hello everyone, Andrea here, and we're on episode 4, Untold Realities, Confronting Access Inequities and Resource Scarcity in Social Work. I have a guest on today, Katie Johnson, who's a clinical social worker in the area. Katie, you want to introduce yourself?
Yes, I am duly licensed in the state of Idaho and Washington. I am also currently a doctoral candidate in higher education leadership with a graduation date in April, so we're coming close to that. And I currently work for a nonprofit organization where we serve rural communities. My research has included mental health in rural communities and rural higher education.
Thank you. So we're going to talk about the landscape of rural mental health, kind of discussing the overall theme that we see and that you see as we're both providers, obviously, but in the community. And then just in brief, like the special skills and knowledge around that and the common misconceptions and stereotypes. And then we'll dive into some of the other topics and going deeper into that. What is your experience around rural mental health?
That is my day-to-day life when I am working. So currently the nonprofit that I work for, I work in a behavioral health clinic as one of their providers. And so I see patients, very diverse demographic patients with high needs every day. So I serve a very vast demographic of clients every day. I think my youngest client right now is about 21, and my oldest client is 68. However, I have seen young kiddos down to age 4, I believe. So within rural social work, being able to be adaptive to the vast demographic that we have and need in our area, as well as the severity of the mental health that I see in the needs daily, where patients aren't having services and haven't had services for years or ever.
I think the big thing about rural healthcare is there's a huge amount of marginalized groups, including farming communities. You work primarily with Medicare, Medicaid,
I do.
underinsured, uninsured. But you've also worked in private practice. So what is different between those two things?
That's a great question. I would say there's a lot of differences. In private practice, it's a little bit more specialized where you can see maybe just anxiety and depression, don't see some of those bigger diagnoses, where in the nonprofit organization I work in right now for community health, I see big diagnoses every day: borderline personality disorder, bipolar disorder, which is a lot of people on my roster right now have bipolar, schizophrenia. I can see some general anxiety, depression, but generally it's big diagnoses of people who've never had services before. So it's a big difference.
What does that look like when they're coming in for services that they've never had them before? How do you start that rapport building? Because that seems to me like it'd be different as well.
It is difficult. I mean, there's some people that come in and they're like, they told me to be here. And you're like, okay, well, so you kind of have to build that relationship with, like, I'm going to meet you where you're at. I'm not here to judge you. We're just going to sit here and talk. And sometimes that means just shooting the breeze for a little bit to kind of get to know them and build that rapport and that safety. And then there's some people that have been waiting and waiting and waiting for services for years and years and years. And finally they're there and they honestly can't keep it all in. So it just comes out just like a river about all the things that they are feeling and what they're working on and what they want to work on and what they need help with. So it's two very different things that can kind of walk in the door, and you never know sometimes what you're going to get with a new patient client.
Do you think there are special skills or knowledge that you had to obtain after attending college because of the education being primarily based on an urban model?
Yes, I would say being adaptive, that's a skill that you have to have. because like we were talking about, you have to be able to see somebody who's really young to maybe an elder, completely different generational component. So lifespans, also just being able to meet everybody where they're at. Like you kind of have all walks of life that come in. Some people who live in extremely rural areas, some people who live in larger cities in the area. A more generalist knowledge to be able to meet every person that walks through their doors' needs.
So in episode one of the things that I talked about was it was an interesting transition for me to go from living in a rural community to being a provider in a rural community. What was that like for you?
Very different, because the world is very small and you see people outside in your community that maybe you don't anticipate seeing. So there's always that. So talking about boundaries, that's where boundaries come in, right? Like I might see you out in the community we live in. I'm not going to talk to you unless you talk to me, kind of things. And then just recognizing that we are rural and understanding there is stigma around mental health and, validating those concerns.
What about in your personal life? Was that different? One thing that I've noticed, and this is not something that happens every day, but it happens often enough. People will come out of the woodwork that haven't talked to you in years, and they're like, "Oh, can you help me find these services? Or can you help me connect with that? Or can you, facilitate these? Or do you know where I could find these resources?" And they kind of use you as like a searchable resource bank.
Yes, that happens frequently. I have a lot of like friends who have kids, and they're like, "Hey, this is going on with my kid. What do I do?" Mm-hmm. And I'm like, "Well, I can't see your kids." I get asked a lot if I will see their children, and I always say that that's a conflict. And so I direct them to resources that can best help them with what they're needing. But yes, I'd say that happens frequently.
Yeah, and it's hard to just say, "Well, no, I'm not going to help you."
Yeah.
And I often will be typing out the message back to them before I'm like, "Wait a minute. Do I want to do this? Do I want to open this door?" Because once you send that message, then they keep coming back and keep asking questions.
Boundaries. I think that's like the theme of all the things here.
Yeah.
Is, like, hey, I can help you identify, hey, here's some resources, but that's about as much as I can do because of ethical constraints.
Yeah. So I want to move on to talking about some of the marginalized populations in our community and the cultural considerations that are in our community. Research states that suicide rates in rural areas have increased by 48%, whereas in urban areas only 36%, and that gap is getting larger. Other research stated that those who live in rural communities are less likely to seek help for mental illness, and they have higher rates of poverty, higher suicide rates, the farm crisis, number of people with disabilities. All of those are higher in rural communities than they are in urban communities. And it makes it hard for those people to want to get services, know where to access services, or even find a provider that does them. Oftentimes in rural communities, there's one or two social workers and they're doing everything. Or, in one of the other episodes I talked about briefly is, I don't see Medicaid people. So where do you refer these people? I take insurance. People can't afford cash pay. They can't afford all of those things. So you work with Medicaid, Medicare, underinsured, uninsured individuals. And I want to know kind of what you see as difference in the culture and around rural living, specifically with those populations.
Yes. So the needs are really high. There's been a lot of people, like I stated earlier, that have never had services before because they've been waiting. In our community, we have extremely limited services, providers in general, but specifically providers who accept Medicare and Medicaid and have a sliding fee scale for those who are underinsured or uninsured. So the needs are high. They are willing to wait months and months to see people to get a service. Yeah. So we currently have a wait list of 60 plus individuals who have been waiting for up to 6 months at this point. And they are willing to wait because there's a hope that they have a provider at the end of their time period of waiting. We have started working with care navigators and care managers to help people gain services elsewhere or just connect with to make sure they feel connected and not lost along the way. So that's been really helpful for more of an integrative type of service.
Waitlists are hard.
Very
like
hard.
I don't have a wait list. Mainly, a lawyer once told me not to carry a wait list because once they're on your wait list, then they think that, oh, I have a provider,
Yes.
I need to stop looking, and they stop looking for that provider, or they end up in the ER and they're like, well, so and so is my provider, because they think that you're their counselor because you're on their wait list. So how do you guys, you talked about the care navigator, how do you guys make sure that they know, hey, this isn't a guarantee of service, this could take a really long time, that to keep looking?
So we have what's called an initial evaluation when we get a referral or a self-referral for someone. They come in, they actually meet with myself or the other clinician at our office. We do a quick assessment, kind of see what they need. Like, what do they need? Because we know they're going to wait. So do they need med management? Do they need peer support specialist services? Because we have those too. So like, what do they need? Why they wait? So we do a quick little run through, a short little assessment. And then I tell everyone that I see, I am not your provider. This is just me seeing what we can get you connected with while you wait. There is a wait list. So I'm very clear about this is where things are at. If you need services, please reach out. But then we also rely heavily on state and national, like suicide crisis lines, that type of stuff. So there's those components, but we just have very clear communication that I am not your provider. There are other providers here, which you'll meet. And then
what if they get into crisis? Because last I heard, where you work does not have a crisis line. You work with these individuals that are, so not only the crisis for the people that you're seeing, but like, what if somebody who's on that list is in crisis? How do you guys manage that?
Good question. So if someone calls in and they're on a crisis, or however they come to us, we have a couple different routes we can go. If myself or the other clinician in our office is available, we'll handle that. Or we have a behavioral health provider who's on, like a lead behavioral health provider who is always on point, who's always like ready for those types of things should they come along. So there's always someone who can take that on if needed.
What about after hours though?
We do have a nurse line for after hours 24/7, so they are able to contact them and then they can direct appropriately.
Okay. Do you guys get many crisis calls?
I don't know, honestly. Personally, my schedule is full every day. I don't hardly ever have anybody no-show because the need is so high, and so I don't get a lot of those phone calls.
I don't know if you came across this in your research, because I know you did some research on retention and stuff. Have you ever come across anything that states that no-shows are lower in rural communities than they are in urban with the lack of providers? Because I don't have a lot of no-shows either.
Yeah, that's a good question. I don't remember coming across anything like that, but I would say that it's no-shows are low. I mean, I have a 96% retention rate of people, and my no-shows are like 2%.
Yeah, the only time people no-show me that I come across is like if they're sick or if they can't get a ride.
Yep.
And usually if they can't get a ride, they're like, hey, can we do telehealth? Because I don't do telehealth, unlike you. I don't love it, but I will do it with somebody who can't get a ride. I have one person who has seizures and sometimes can't get a ride over, and I'm like, okay, yeah, we'll just move to telehealth. But yeah, you don't see that often. And that makes it, I think that, depending how many you see, can contribute to burnout as a provider because you're seeing a lot of people.
Absolutely. It can. And that's a big concern, especially for community health, because we see a lot of people through the doors every day.
Well, and one of the articles I came across talked about, it was actually for Washington State, and it talked about the crisis cycle. I talked about this in one of my very first episodes, but it talked about how, because there's a lack of hospital beds, they're being very picky on who they put in those beds. And so then people are not severe enough to maybe get to those beds, but they're too severe to be seen individually. And then you have this crisis cycle that goes round and round and round and round. And then you have these providers that are acting, probably less so in integrative health or nonprofit, but I see this because I do more of it, is you're doing crisis services as well as individual services, because there's nowhere for my clients to go get crisis services. We refer them to, the local people, but that isn't always meeting that need. Or they're not severe enough to meet that. So when they call the crisis center and they're like, well, you don't meet these criteria, so we technically can't do that, because they're very strict on the criteria now, because there's such a lack of providers and lack of resources in the area. There's only so much you can do and so much you can spend. Um, so I think that makes an impact into who you're seeing. You know, I know we talked before, and you're like, if they have insurance, you know, you try to refer them out. And like, if we have Medicaid, Medicare, we try to refer them where you work because, or an intern if that doesn't work, but trying to get them services that they can either afford.
We're kind of seen as the hub of not things simple. So if there's anything that's not just generalized anxiety, depression, they are sent to us. So it could be somebody who is completely unmedicated schizophrenic. And they're like, oh, you guys can see them. And it's like, well, that's kind of not what we do. Like, yes, we see like chronic diagnoses and like the big diagnoses, but there are some obviously that are outside of our scope of practice. So that's where our care navigators come into play. And we actually do quite a bit of referring to intensive outpatient programs. So we have connections with several of them, and we're able to get people connected virtually because we don't have any of those services here.
I want a list of those services.
Yes. So we actually have good connections with several of those places where patients can get those more intensive services that we're not able to offer and that we don't actually have in our community, and then they can come back to us after they've kind of stabilized a little bit. So that's something we meet regularly.
Now, there's a lot of research out there that says rural communities have a higher rate of severe and persistent mental illness and all of those big diagnoses. Do you see that to be true more in the Medicaid, Medicare, you know, the poverty population than you do in those that have insurance and have, you know, are in middle class?
Absolutely. I think there's a lot that goes into that. I think one is because they don't have access to services, and their family hasn't had access to services. So there's a lot of generational components there. Poverty, obviously, generational poverty. With that also, I think, comes trauma, right? And some of those populations, they have generational trauma, or they're more susceptible to trauma. They have a lot of trauma in their life. And research has shown that if trauma is not dealt with within the first 30 to 90 days, it can take a lot longer to work through than if you address it right away. Well, a lot of these people don't have access to care, so their trauma is going to go untreated for years and years and years. And that stems, as we know, lots of other diagnoses.
Right. The other population that I want to touch on before we move on to kind of, you know, barriers and stigma is farmers. So one of the studies that I came across talked about how suicide among farmers is double in rural communities than urban. Well, I think one of the reasons is you have more farmers in rural communities, but they talked about how farmers are the foundation of rural communities, and it's such a stressful career with the challenges around weather, supply and demand, social isolation, the financial issues around machinery malfunction, and those all increase suicidality. Do you treat anybody of the farming community, and what do you see that's different?
Yes, I do. And I would say what's different is exactly what you just listed, right? There's a lot that rides on how the crop's going to be this year. Their finances, right? Their mental well-being. You know, is it going to be a great year? Maybe stresses are down. Do they have help? Like, do they have someone who can come in and drive truck, right? So they're not doing it by themselves. There's a lot of different components to that. What I have noticed within the individuals I see who live in those farming communities is that there's a lot of stigma around mental health, and there's a lot of, you're not tough if you talk about what's going on, right? How you're feeling. And so I actually have an individual I see via telehealth, because that's the only service I provide right now, who does it within their home. And I believe that actually provides them with a sense of safety almost to have services and not feel the stigmatization of going out for services, but able to also get the care that they need. So I think telehealth could be a bridging that gap maybe a little bit.
So that brings me to the next thing, which is stigma around mental health in rural communities, which all research that I've come across states that stigma is the number one reason people do not seek treatment. What do you see around stigma in your work?
From a personal perspective, I grew up in an extremely rural community of 1,000 or less. And so we didn't have mental health services at all. And honestly, I don't ever remember talking about them even in school.
Well, there was no telehealth because internet wasn't really a thing.
We had dial-up that wasn't great, right? And so there's none, right? And it's still, even I have friends that still, live in those types of communities, and really we don't talk about mental health, especially men. We don't go there. So I think there's a lot of stigma around mental health services. However, I feel like that is kind of changing. I don't know if it's getting better, but I feel like it's changing because we are talking about mental health more. There are people in rural communities that are seeking services and seeing change and seeing growth. And they're like, hey, this is actually working for me. So they're actually talking about it more, which I think is how we get out of that stigma. But there's, a lot in those communities. Everybody knows everybody's business. Everybody, right? And so if you walk into the grocery store, everybody knows. If you go to the hospital, the next person you see on the street is, why were you in the hospital? Mm-hmm. Right? Everybody knows. So that's, I think actually not having a mental health clinic in those communities is actually good, because anybody who walks into that building is going to go, what were you doing?
Well, now we have telehealth.
Exactly.
I find that interesting, the differences between Lewiston and Clarkston. So Clarkston, even though it's we're the same community, it functions a lot like a small community, a really, really small community, because it is smaller than Lewiston. But, you go down to the store, and I walked down the store when we were painting this office, and the lady's like, oh yeah, you moved in down the street, didn't you? And I'm like, you're 2 blocks away. But she knew exactly what I was, what I was doing. And I'm just like, everybody knows everybody's business. And I saw that too when I worked where you work. I'd work in Lewiston, I'd work in Moscow, and Moscow functions like that too. Lewiston functions less so like that than of the 3. But it's interesting. It's like we had this community that just had a core group of people, and then they just expanded. Yeah. And so you still have those same. So I think in general, and, I'm not in other rural communities, but I do think that Lewiston functions more rural than some other town that would be the same size because of the farming, because of the culture, because of who lives here and who started it, and they just kind of stayed. But telehealth is expanding that in.
Sure is.
Bridging that gap. Do you think it's lowering stigma?
I do. I see a lot of individuals from communities that are outside of our community a lot. I mean, I see people who live hour to 2 hours away every week, right? So we're bridging that gap, but I think that providing, if they talk about it with their family or friends that they're, in services, I feel like that's going to start bridging that stigma gap there.
Yeah. And we have, when people come into our office, we talk to them, or we always show them the back door, because a lot of people, we're on a main street. People don't want to be seen coming in and out of a counseling office. And so we have this huge parking lot in the back that could be for any of these businesses around here. And oftentimes they will go. I've had one person that said, no, I have to come in the front because somebody they knew lived in the back.
Sure.
And they're like, we can't do that. But there is a huge stigma that I see anyway in what and I don't work with Medicare and Medicaid, but just walking in the door.
Absolutely. And I feel like a lot of that actually comes from people who maybe have sought services or know somebody who has sought services, and they didn't get anything from it, right? And so why would they bother to get additional services, or someone who never got help? And so whenever I see somebody for the first time, I always say, I may or may not be the provider for you. It's really important that you have a provider that can meet your needs and meet you where you're at. So if it's not me, tell me, and I'll get you to where you can, right? Because not every therapist is ideal for every client. It doesn't work that way.
Yeah. And you guys don't have a waiting room either when you do telehealth. Do you think that decreases the stigma?
Absolutely. I think there's actually, so I was really nervous about being telehealth, and I love it now, secretly. Not secretly, I'll shout that from the buildings. Love it. However, I see a totally different side of people because they're at home, or they're in their car. They're in their private comfort space. Now, do I see the other side of it to where maybe not such a healthy environment? Absolutely. But sometimes that actually helps a little bit because we can really utilize things and skills when that happens, right? But I actually think I get to see a whole different side of people.
People see each other in my waiting room all the time, and they're like, oh, I didn't know you went here. And usually it's a positive thing. Sometimes, though, it's not. And we've had to make schedule adjustments so that people aren't in the office at the same time to avoid that issue.
Absolutely. I think that happens a lot. I mean, there'll be times where I'm sitting with, I'll be listening to a client and what happened in their life, and then later in the week, I talk to a different client, what happened in their life. And it's the same event, but I had no idea that they were somehow related, right? Because you would have never guessed, never had it come up. And, I think that happens in rural communities way more than urban areas because everybody knows, there's connections all over the place. And it's surprising.
Well, and I'll just share a little bit about the thing that happened to me when I tried to hire a provider that had a private issue that they had, and it became very public once I posted on Facebook that I hired this person, and it just blew up. I don't think that would have happened in an urban community because it would be it was none of my business anyway.
Mm-hmm.
But because it blew up and everybody then in the community knew, that's why I say Lewis and Functions is a very, very small community, is everybody in the community knew. I was in Costco the other day and somebody was like, Dragonfly, right? And they're like, I just felt so bad when I saw that going on Facebook. And I was just like in line getting a prescription at Costco.
Mm-hmm.
And I don't think you had, like, that wouldn't have mattered. Your provider can do more what they want to do in an urban community than they can a rural community because there's less likely a chance of somebody finding out.
Mm-hmm.
And this became a level of self-disclosure that then now was self-disclosed to everyone when it shouldn't have been. And now that was kind of like that oversharing that we can do as a therapeutic relationship, but then was damaging to the potential of new people coming in or seeing that provider. And so the level of privacy that we have, I think, makes it hard.
Mm-hmm.
But that also stigma too, because that's why people don't want to come in for services.
Exactly.
The lack of privacy.
Mm-hmm. Well, and I think, if you wear something like a logo of where you work, you better represent where you work, right? Yeah. Because you're in a community and everyone goes, oh, you work for so-and-so.
Well, and if you have a bad experience with that person, then that increases the stigma because they're like, well, I'm not going to go there. Oh, that's why I don't have therapy. That's why I don't want to do that.
Exactly. It also, I think, eliminates the ability to do like exposure type therapy. Like, let's say a client has difficulty going to a store. Like, they're not going to want me to go with them, right? Because who wants to take their therapist to Walmart when you know everybody who's there?
Yeah.
No one.
Well, I remember one thing I always used to tell people when my kids were little, really little, because, I have one kid that's on the spectrum and they both have ADHD. And I said, just so you know, if you see me out in public, I'm not going to say anything. But if you come up and talk to me, my kids know what I do and they have absolutely no filter. And they will say, oh, are you a client? And so I said, make very sure that you don't need that private. Otherwise, I will ignore you. And I think people don't do that. And then people get burned. I've had a lot of people come in my office and they're like, well, I had this experience. And it was awful. I had somebody come in my office the other day and they were like, yeah, the therapist just didn't show up. And I would come on a Saturday and they wouldn't be here. And then she'd be like, well, I'm worried about them. And she goes, that's not my job. I shouldn't be worried about them. But it took her 6 months to call us and get somebody else while she was waiting for that therapist.
It's because it's that hope of a need, right? To be filled.
Yeah.
But I also think you brought up a good point where we do have families. And when we go out and I have had this conversation with my husband and my son, like if someone comes up and talks to me and you don't know who they are, it's okay just to walk away. Don't ask any questions, right? Or we actually have a code word and I say whatever our code word is, and we actually turn around and walk the other way because that's not okay. Sometimes I don't, it's my personal life and it's their personal life. Right.
Yeah. And my kids, obviously they don't do it now.
Well, sure. They're old enough that they don't. Yeah.
But when they're young, they don't understand and they figure if they don't know who they are, then they must be a client.
Right. Exactly. Or if they'll say oh, who was that? Well, I can't tell you that. Well, that tells everything. I know. That's not a HIPAA thing. Sorry, you just can't say anything.
Yeah.
So I think there's a lot of that in rural. You could go through, this has happened to me actually, went through the drive-through at a restaurant. Who's at the window? There's a client there. And they start talking to me and I'm like, oh my gosh. This is happening in the drive-thru.
That happened to my mom. She went to go get something, went to go get us lunch for people who don't know, my mom's my office manager. And she took my business card to pay for lunch. And somebody goes, oh, that's your daughter? Oh, I just love her. And it just went on and on and on and on about all these things. And my mom's like, can I have my food?
But I think that also points to another good thing. And I know we're kind of off topic.
That's okay.
With clients. But in rural, a lot of providers know a lot of providers, right? We know a little bit about like everyone in the community.
Yeah.
And so there's a lot to that.
There's a stigma with that though too. Like
Absolutely.
when my husband was looking for services, I was like, telehealth out of the area.
Yep.
When I was looking for services, I saw a counselor up in Coeur d'Alene because I was like, no, I don't want to see somebody I know or that's going to show up at a continuing education or a conference or something that I go to.
Yep.
So I think there's a stigma within providers getting care services for ourselves, which research says it's best practices for us to get therapy. And yet there's this really big barrier to doing that.
Especially in these areas.
Especially in rural communities because you know all the providers.
So where do you go? Outside.
Yeah. Thank goodness for telehealth. That is one good thing to come out of COVID. Probably not the only thing to come out of COVID, but it is the telehealth, it is good. Yeah. Okay. So that's a little bit about stigma. I know we got off the topic of it a little bit, but I think we wrapped it back around. The other huge topic that I want to discuss is the barriers to care in our areas. So, the biggest thing is lack of resources, lack of transportation, the financial barrier of going places. Maybe they don't have a car, maybe they don't have gas to get there. They don't have access because we don't have providers. And so then they have to, where telehealth can bridge that gap, but that doesn't necessarily work for med management or psych testing, especially psych testing. They don't do a lot of that on telehealth.
Nor do we have that here. And most people have to go 2 hours at least to get a lot of the services if they're Medicaid or Medicare, or they're trying to find somebody who does a sliding fee. But even the sliding fee for psych evaluations is like $200. Who can afford that when you're
that's at WSU, which is a college, which should be cheaper. But it's not. And they don't take insurance. So then, and they only do one test at a time. So, you go into a psych provider. There's one in Moscow I love, and she does everything. But you go to WSU, you get ADHD. You can choose autism. You can choose a developmental one, but you have to choose each one is that $200. And so then just builds up and builds up. And the school they're way far out on getting testing done, and they're not going to test you if they can help it because then they have to pay for that. What other barriers do you see for care for those high risk and marginalized populations?
Well, I think transportation, besides financial components of the insurance, right? I think transportation issues is huge. Not only are cars expensive these days, way more expensive than what they probably should be, but gas is expensive. And a lot of people, they only have so much gas that can last them so many days, like between whatever. So they really are thoughtful in how they utilize their gas. And so getting to services is difficult.
Well, geographically, we're so spread out.
We are. Yep. And so think about transportation issues. If someone lives an hour and a half away from here, let's say they live out in the Kuski-Kamia area, but where they have Medicaid, Medicare. So where do they come? They come to us, right? Because we're the only providers. Who's going to drive that once a week and who can afford to?
Well, and the other thing too, this is what I run into with my Medicare people, is Medicare will transport you, but you have to live under 100 miles. And we are 102 miles from Spokane. So they will not transport to Spokane because we are 2 miles over, and they won't meet you anywhere because they have to pick you up at your house. And so then there's no ability to get that transportation to and from appointments.
Big appointments.
Yeah.
Medical appointments, anything like that. Yeah. Yep. And there's, you have to call so many days in advance.
2 miles.
And you have to, that's a big thing, right? 2 miles is not that much, but it's a big thing. It's a big barrier. Yeah. Right.
And a lot of people also don't know that they can access some of the services like Medicaid will reimburse for mileage and stuff like that, but they reimburse. So they have to have the money up front to pay for those. And then they get reimbursed and they have to know how to do that.
And so the paperwork for that isn't very friendly. But the other side to that is, like you said, they have to have it first. A lot of people don't have it first, right? So that's one reason why when we're doing telehealth, I like being able to reach all those areas. They can still have access to care.
Because they don't have to drive.
Because they don't have to drive anywhere.
And you guys eliminate the financial cost to it because you don't turn anybody away for their inability to pay.
Correct.
The sliding fee scale.
Correct.
And a lot of those are nominal fee or zero.
Exactly. Especially for mental health services, we kind of have a different sliding fee scale for mental health services. And it's so small. It's so unbelievably small. because we have a lot of people who are, let's say, private insurance, but it's one of those deductible plans that are so high because they maybe are $1 over the maximum requirement for Medicaid. Right?
Well, and in Idaho, if the minute you are over that dollar, you're off.
Right.
And
exactly.
it's not like there's no gradual decrease off of any Medicaid services. So it's just like, nope, you don't meet the criteria today, so you're off.
Yep.
And then you have to, so people aren't working, they're not doing these things that could help their mental health because they're trying to keep their service, their insurance.
Yep. Those high deductible plans are great to have for catastrophe, but no one can actually afford services still. And so that's where I work, is because we can kind of bridge that gap and we won't turn anyone away. So we try to work with people as much as we can with, and then we also have a lot of uninsured people because they don't want those high deductible plans, because what's the point, right? I'm not paying whatever a month. I can't afford that for a plan that's really not going to benefit them. So we see that quite a bit too.
Well, and catastrophic things, oftentimes hospitals will write those off. So then what's the point of having a high deductible plan? Because that can be written off. Depending on where you go for the hospital.
Right. There's a lot to it, I think, with the financial components of services. Just not even just mental health, but just medical components anyway. I think insurance is deciding what people can and can't have care for.
And I think there's so much shame around it. Like, I get frustrated, and we have insurance through my husband's work. Thank goodness we have really good insurance. But I get anytime that, so our group number changed this year, but it also changed last year. And every single time I make an appointment, not 24 hours after I make that appointment, your insurance doesn't work. They're calling me. They're like, well, you can't be seen because you don't have insurance. No, I have insurance, but they treat you kind of like crap because they're more worried about getting paid than they are providing the service. And then they're shocked when people don't go in for services. Well, I wouldn't want to go in for services either. I had a lady that came in and her husband was seeing a provider that did not take insurance. And so they said, oh, we'll give you a super bill, but they never showed them how to do it. So for 4 years, they've been paying $100 every 2 weeks for this and never submitting it to insurance. And I'm like, bring it in. I'll show you how to submit it. It's not that hard. But it takes like 5 minutes to show somebody something that could change their life and make things so much more accessible to them, because therapy adds up.
It sure does.
Even if you only have a $25 copay, it still adds up.
It sure does.
But it's also something that theoretically helps you get to be in a better spot in life. So it's worth it. But it also, is it worth it if they're feeling so down on themselves and having so many financial barriers? Which one's helping?
Right. That's a great point.
One of the big challenges in rural communities is limited resources, right? So if you need to refer somebody out, can you do it?
The answer is no. No, that maybe is not true, but extremely limited. Like, we try to refer people out if we can, right? If they have private insurance. There's nowhere to go. Everybody either has a wait list or is full. So that there's nothing there. Psychiatric medication providers are extremely limited, extremely full. So what do you do? Luckily, I have one on my team. So we're able to utilize her. But what if it's out of her scope of practice? Where do you go? What do you do? There is no referrals, right? Or they're out of the area, and then you add more barriers like transportation issues and finances. Again, those kind of circle back. Luckily, with the organization I work, we have a lot of connections to different things. And so we're able to kind of utilize that to try to get those connections in bigger areas. But, I have a lot of people I work with who work in an urban area, and listening to what their resources are compared to our resources is like, I don't know what you're complaining about because you have them. We don't have them.
Well, and we were having a conversation the other day where you were talking about how they were talking about something that they do that works, and you're like, that's not going to work here.
Oh, yep.
Trying to have those services and what works in an urban community won't work here.
It's not the same thing. We are not the same. You cannot treat us like we are urban, because those don't work here.
Well, and the nearest place to get something is 2 hours away. We're like this town of 40,000 just is plopped in the middle of nowhere that has nothing around it for 2 hours.
Except we got beautiful scenery.
We do have beautiful scenery. And I mean, this is not just medical. Like, I had to go get my windshield fixed, and these new windshields have all this calibration stuff. And they're like, well, you can go to wall to wall. I'm like, I'm not going to drive 3 hours to go get my windshield fixed and be there all day. And I was like, it's not just medical. It's not just these services. It's everything. We just, we do. We have beautiful outdoor scenery, beautiful things to do outside. But any resources are scarce. And I was talking to my students on Friday, and we were talking, I said, I feel like being a therapist or being a social worker is like an art form. You know, you have to get super creative in how you're helping these people. We're, you know, in an urban community, oftentimes you are talking to the person and then they go home and you see them once a week. In a rural community, I'll get a call or a text or an email, you know, to the office, and it says, you know, I need this, or can you help me with this? Can you do whatever? And because they need a little bit of case management as well as just therapy.
Yeah.
Do you find, what are some creative things that you do?
Well, that's a good point, because when I was in private practice, we didn't have case managers. And so we did case management, right? Along with therapy. Now I'm very fortunate to have care navigators on our team. And so if we need something like that, we kind of pass it to them. But you do have to be creative in a lot of different things. So luckily, that part I don't have to do, so I can focus solely on my area.
What things do you feel like you get creative at?
That's a good question, because I feel like it's all the time, because you have to be able to, every person who walks in is different from the one before by a lot, right? Not one person is even close to the person that maybe that worked for them. So you have to get real creative with coping skills, for one. You got to get real creative with those sometimes. Because there is stigma around, they're having a panic attack, so how can they do it? Maybe have a coping skill secretly.
Yeah.
So people aren't noticing.
So people aren't noticing, they're taking deep breaths, or they're counting or whatever.
Yeah. Sour candy works great.
Yeah, I didn't hear that. I heard that the other day. I was like, somebody's like, I just keep sour candy in my purse. And I was like, I did not know that.
I tell patients to put them in their pockets all the time. Or their purses. But it works really good. Or like warhead spray. Works really good too. So it's finding different ways to make it so it's not so noticeable. Or let's see, what are some other creative things? I use a lot. I
think it's hard to sometimes come up with creative ideas or what you do because you do them every day, and so they're just part of your practice.
Yeah, I think that's it, because I'm like, I don't know, I just do whatever I need to do.
I think that's right there is what rural is different than urban. You just do what you have to do.
You just do what you need to do to meet the person's needs the best that you can, or find someone to help.
Yeah, and I think in a rural community, at least I feel this way. I feel like I need to, if they have a problem, say case management or whatever, I feel like I need to connect them with we have bachelor level interns right now that we send for them to case management because it's easier than, we don't have to do it. We're not taking therapy time to do it. But it is just like, okay, you see this need. Well, we need to help them solve that need because there's nobody else that's going to solve it.
That's exactly it. You're here. Let's just do it.
Yeah. And I think that's something that's different in rural versus urban.
Well, I think you take a place like where I work, and we have a team that is circular. We have whatever need comes up, we have someone you can go to for that. You need help getting on insurance, we got someone for that. You need help getting a hotel room for the night or a gas card, we got someone for that.
Yeah, but what about people who are not going to those places?
Send them our way. No, but I think that, that's what makes a place like where I work great. Because we have resources. Yeah. Where other places don't.
Unfortunately, it's the only place in town that does that.
It is one of the. Well, there's another.
There is another place, but nobody uses it.
Really. And it's not the same.
No, and it doesn't function the same. I think the key difference is, like the other place, you have to sit and wait for them to maybe have an appointment, because they don't do appointment based for that first intake. You just sit on a Tuesday afternoon, which, do people have time to do that? Can they leave their jobs? Can they do these things? Whereas how yours works, they're a patient there for the primary care. I know that's not required right now for behavioral health, but oftentimes there are patients there, and then they are connected within all these web services. And I think telehealth is a huge thing in rural communities, bridging that gap to provide more resources and support. And even other professions of social worker do telehealth.
Yeah.
It's not just clinical practice.
No.
So a lot of these services are going on telehealth. So like the IOP programs and stuff like that. Like we just did a training with the Emily program, and they were talking about their IOP program.
Yeah, great program.
I would love to hear what other IOPs you have connections with, but I think telehealth has really provided more of those kind of services. Also, support groups and therapy groups, case management, all of those things can be provided online now to help bridge that gap for resources. There are good things about rural communities and being a rural provider. What's one of the best things that you like about being a rural provider?
My favorite thing I'd say about being a rural provider is you never know what you're going to get that day. When you go to work, you don't know what you're going to, you don't know. You might think, hey, I know what this day is going to look like, and it doesn't turn out that way. Or like I don't have all easy clients and I don't have all hard clients. Kind of having that mix is really nice, even though I do have probably more of the harder chronic diagnoses. But I like that part of it. And I like closing that stigma, and I like building people's trust. So they're like, ooh, I like this. Or I love people when they say, oh, I didn't know about this therapy thing, but I love it. And I tell everyone, right? Like that's my favorite. And when they're like, hey, I think mental health services are for you, and they help advocate for mental health services, and hey, this is how you can get help. So I think that's how we bridge that gap with stigma.
What's the best thing about working with marginalized groups over people in private practice?
I would say my favorite thing about working with these marginalized populations is that the growth is significant. Like you see from when they come to when they leave, just this huge, like life-changing, right, type of work. And you know the people who are there who want the work because they put in the work every single week, and they come back and they're like, guess what I did? And it's so exciting to see. And it can be life-changing. You have somebody who maybe wasn't working. Now they're working, they're stable, they have, a relationship, right? Like there's all these things. They're not having 5-6 trauma triggers a week. They maybe have one, right? Like it is significant progress and work.
Well, thank you very much for being on here today. It's great to talk to you.
Yeah, same.
If there are stories or issues that you face in your practice and you would like me to discuss those on this podcast, please send me a message at theruralsocialworker@gmail.com, and I will be happy to take a look. One of the goals of this podcast is storytelling, and I believe that to be impactful, you need context, and that is where stories come in. They give us something to work with and something to build on. I also believe that stories from multiple different rural communities will offer more information and provide more support to rural social workers everywhere. So with that said, I hope you enjoyed this episode and will subscribe for more. Thank you for joining me for another insightful episode of The Rural Social Worker. If you've enjoyed our exploration into the vital work of social work in rural communities, be sure to subscribe, share, and connect with me on social media. Your support helps me continue my mission of closing the gaps and fostering resilience in the places that often go unnoticed. Remember, this podcast is not a substitute for official supervision in your professional journey. Until next time, stay engaged, stay informed, and keep making a difference in rural communities.